And I think that's what this is all about, using these tests to guide management for the patients, and as well as detecting open-angle glaucoma earlier, and also using it, of course, diagnostically to help differentiate different types of diseases. We're going to look at this a little bit in light of using SLT as well, since I should know a little bit about SLT. Again, a commercial relationship with Diopsys as a speaker. Overall, I think everybody knows this. Electrophysiology is an objective measurement of the strength and speed of the visual signal from the eye to the visual cortex. It's really the only objective measurement we have, actually, of the entire visual system. What are our tools to evaluate the glaucoma patient? Well, we have subjective tools, of course, such as structurally photography, fundus photography. Functionally, of course, we have the visual field, which we're using all the time. It's, again, a subjective test. And then objective tests, optical coherence tomography, OCT, which, of course, is pervasive now. And so our equivalent functional test, which is objective, is the pattern electroretinogram or the electroretinogram, or you can also say VEP. So I think we know visual fields are great, and we use these for, we've used these, of course, since its inception, but we found out that, many years later, when Quigley did his studies, that the visual field, by the time you get a visual field defect, you've lost about 50% of your retinal nerve fiber layers. So this is where, of course, OCT has helped us a great deal in looking at the structural changes, and we know now that structural changes can occur in the OCT before and precede those changes in the visual field. And as well, that OCT changes should somewhat be equivalent to changes in the visual field, or coordinate with those changes. But really, we haven't, so again, these are structural changes and mostly subjective, but we haven't got any functional objective study, and that's where the VEP and PERG come in. So this is the system, the Pattern ERG. It does flicker ERG, it does VEP as well. It's a simple automated protocol. Diopsys has brought the university type system, which was, of course, why most of us never used it, because we're not going to send our patients to the university to get this test unless they have some severe problems. And they brought it into the office setting. So it's an easy test to do. We do it in our office. We can do it in about 15-20 minutes per patient or so. And it's really pretty operator friendly. They've developed this sensor that goes on the lower lid. The original devices used either this gold foil or a contact lens, which of course was also problematic for the patient. So the patients tolerate this very well in the office setting. So what are the indications? We're going to primarily talk about glaucoma, also use in maculopathies. So why is it useful in the glaucoma patient and for maculopathies? Again, it's the only functional objective test we have. It's an alternative test to our current procedures. It's particularly useful for open-angle glaucoma patients or glaucoma patients, because what it's detecting is changes in the retinal ganglion cell function. And these cell function changes can occur before other structural or functional changes occur. It can also help us determine what patients with elevated pressure should be treated. In other words, it's going to give us some indication, and I'll go through this, what patients can actually be, should we be looking at for treatment. So I think, again, looking at the spectrum of glaucoma from undetectable disease to functional impairment, as we know, visual field changes are down here, as I've indicated. So by the time you get 50% the nerve loss, you're in here. So, of course, this is why we're using OCT, now is probably the main approach to detecting glaucoma and following it, because we can see these retinal nerve fiber layer changes earlier. But PERG is even detecting it earlier than that, because it's looking at ganglion cell death and axon loss, and when these cells are actually undergoing stress. So PERG really is looking at the stress response to these cells. They're still alive. They're not dead. OCT, they're either there or they're not there, but they're not telling you how functional they are. So again, that's a structural objective test. So I think also looking at the OATS study, I think this is important. You know, 10% of individuals with elevated intraocular pressure actually develop glaucoma. OATS study estimated 1.5 million of these patients with elevated pressure are receiving medication. So in this case, we're probably over-treating. So this PERG may help to distinguish these small 10% of the patients that actually require treatment, and of course that will be a significant savings on medications. So how do we use it in our study? Again, it's a complementary test. We're not using this as a single test. We usually do our other tests as well, but it can clarify diagnosis. Again, we're using it a lot when these standard tests are unattainable or unreliable. And of course, visual fields are not usually the most reliable approach to studying these patients. When they're inconsistent or borderline. And again, we can also begin to use this to monitor functional changes and alter our treatment and efficacy program. So the pattern electroretinogram. Again, this is a stress response. We're looking at the stress response of the retinal ganglion cells. The retinal ganglion cells, as you know, and the photoreceptors are high metabolic demand cells. So by looking at this pattern ERG, we're actually detecting how they respond to the stress. For the pattern ERG, the retinal ganglion cell signal is primarily what you're looking at when looking at a steady state pattern electroretinogram. So those cells are actually generating most of that electrical signal. Let's see. So what we've done, again, what Diopsys has done and what we're doing here is, like OCT, we've moved from the time domain, which was the original OCTs, to a frequency domain using fast Fourier transform mathematics. Likewise, in PERG, there was transient VEP, which is a single sort of flash, versus the frequency domain, which is a steady state, which is a more prolonged flash with an exposure to the stimuli, creating a steady state response. So again, we have contrast sensitivity and concentric PERG. In glaucoma, we're using mostly contrast sensitivity, looking at high contrast and low contrast. And again, at high contrast, what's happening is you're creating a high metabolic demand on the retinal ganglion cells. So this is more likely to be affected if the cells are not healthy, if they're suffering. So there's high demand and then low contrast, which is a lower demand on the cells. And this is basically the area that you're actually measuring with pattern electroretinogram. So here's basically what the report looks like. So you do the test. You have, this is a normal, healthy pattern electroretinogram looking at three variables, three measures, the magnitude D, which I'll go over, and the magnitude D ratio. It is color-coded. There is a normative database. This is a dysfunctional pattern electrogram. Also, what you want to see is these nice sinusoidal patterns. So this means that these cells are all sort of overall healthy. They're in sync. They're working together. As the cells begin to become less viable or can say begin to suffer, then their intrinsic variability decreases, and what you see is a change in the waveform shown here, and likewise a change in the magnitude. In other words, the number of cells which are actually producing the electrical output, as well as how well they're in sync. So we see these changes here. And then after a certain number of tests, you can follow changes in the magnitude or magnitude D with a trend analysis. Again, so the magnitude sort of magnified here, again, is the retinal signal. It's basically the amplitude. They're calling it the magnitude, but it's the amplitude of the signal, how big the signal is. So if you have a lot of healthy retinal ganglion cells, you're going to go to good magnitude. If you have less retinal ganglion cells present, in other words, in these patients with significant retinal neurofiber layer loss by OCT, you'd see a lower magnitude. The magnitude D is a numeric description of this waveform. In other words, if it's a nice sinusoidal wave, it will have one numeric value. If that wave becomes more irregular, this magnitude D will drop. And then the magnitude D ratio is the retinal signal intrinsic variability. In other words, how much this varies. So it's another number basically describing both the magnitude D and the magnitude. And it has some prognostic value. So again, magnitude D, all the cells are in sync, and so you get a nice waveform. If the cells are not in sync, they're being stressed, especially under the high contrast sensitivity. You see that the cells are not in sync, they're not emitting the same signal strength, then you get this change in the variability. So a decomposition of the basically sinusoidal pattern. So, you know, what's our current assessment of the glaucoma suspect? Of course, now we're looking at these patients, OHT. They develop some borderline thinning on OCT, so you see changes in your OCT. Maybe you still don't see any changes in your visual field. Then you see even more changes in your OCT because many of us like to confirm that there's changes. And you get to more significant retinal nerve fiber layer loss, and then we, of course, treat. I think the idea behind PERG is, again, to look at this earlier. We see here patients with OHT, but look at their patterns are not nice and sinusoidal, suggesting that these cells are already under stress. They already are potentially suffering. So the idea is to potentially treat these patients earlier and see an improvement in actually the pattern electroretinogram. And we have some studies. So again, in review, so it's detecting changes in the RGCs when the cells are compromised. What we have again with OCT, HRT, and those tests is that they're telling you that the cells are there or they're not there, but they're not telling you anything in between. The pattern electroretinogram is telling us what's happening in between here, what's happening with their sort of viability of the cells. And also, if of course your amplitude is reduced, then a number of those cells are being killed off. So this is a study that just came out by Dr. Katz and coworkers at Wills, looking at steady state pattern ERG using the Diopsys system versus transient visually evoked potentials, which is the sort of time domain portion using VEP actually in glaucomatous and healthy eyes. They looked at comparison of 41 patients with OAG, 41 normals. They looked at PERG versus VEP, transient VEP. And what they basically found was that the SS steady state pattern electroretinogram was able to discern between glaucomatous and healthy eyes with a fairly high incidence. And overall, they found that using the high contrast steady state PERG, that they were able to reasonably detect with about, I think, over 75% those patients with glaucoma versus normals. So their conclusion was that SSPERG was superior to VEP in its diagnostic capabilities and is a essentially valuable diagnostic tool for patients with glaucoma. This study likewise looked at early glaucoma detection from Baskin-Palmer, looking at patients who were glaucoma subjects, and PERG in this case, they found anticipated equivalent loss of OCT signal by several years actually as many as 8 years. What they noticed was it took about, to get a 10% change in the in the OCT required, say, up to 4 or 5 years, up to 8 years. To get an equivalent change in the PERG took about 2 years. So really, PERG was able to sort of detect changes in these patients up as early as 2 years, actually, before there were changes in the OCT. And likewise, the American Academy of Ophthalmology says it may improve our ability for the glaucoma specialists to look at these patients with glaucoma who are glaucoma suspects. So again, PERG in glaucoma, it may be advantageous, I think, in the early stages of the disease. Again, the amplitude of the signal is proportional to the volume or the number of the retinal ganglion cells present and the physiologic integrity of those cells. A reduction in that amplitude again reflects reduced activity, but they can be dysfunctional, but yet not dead. And this like OCT, detects changes before visual field changes can occur. It's also been used for macular function recovery, and we're looking more closely at looking at PERG for recovery, so not only detecting the disease, but also detecting the influence of medications and treatment on the disease process. And they're doing that with, I'm not a retina specialist, so looking at it for PDT, also diabetic changes, diabetics as well. So again, PERG, unlike OCT, allows us to look at both progression along the entire pathway, both improvement as well as progression. This was another study. IOP lowering can improve retinal ganglion cell function measured by pattern electroretinogram. In this case, they used a transient pattern electroretinogram. What they found was in this group of patients, 24 patients basically with pre-parametric glaucoma. They had pressures which were elevated. They gave them Ganfort, which was bimatoprost plus timolol. They looked at their PEGs before and afterwards. If they dropped the pressure by 31%, they got a significant improvement in the pattern electroretinogram. So significant IOP lowering can improve the retinal ganglion cell function as measured by pattern electroretinogram. So that's, I think, a very good study showing that we can, if we can get these patients early and treat them, that we can see improvements in their electrical activity and hopefully maintain the viability of these cells long term. So some cases now. So this is a case, this is basically some of the cases and how we use it in the office, sort of a general overview. Indian female, visual acuity 20/20, pressures 18/17. I do a lot of Pascal pressures. Does anybody do Pascal pressures here? Does anybody know what the Pascal tonometer is? Pascal's a dynamic contour tonometer. It's not been widely used by ophthalmologists, but it's actually probably the pressures measured by the Pascal are probably more closer to the manometric pressure than applanation. It actually sort of reduces the sensitivity, its influence, corneal thickness influence on the pressure is not as important in Pascal tonometry as it is in Goldmann. So it's it's giving you a sort of a different pressure measurement, but I think again potentially a more accurate pressure measurement. So we do this especially in our patients with glaucoma suspects and low tension glaucoma patients. But anyway, Pascal pressure was slightly higher. You would expect to see about a 3 millimeter difference between the Goldmann tonometer and the Pascal tonometry in a group of normals. So that's what you would expect. And this patient was on COSAP twice a day. This is her field. Not a good field taker. This is one of those patients, not a good field taker. And here's her discs, which look obviously very good. So she has very nice discs, optic discs, some little bit maybe asymmetric cupping. OCT is suggestive that there's some thinning of the retinal nerve fiber layer. inferior and some borderline changes superior in the left eye. And we did both a VEP and a pattern electroretinogram. I sort of like to do the VEP, which isn't really a VEP talk, but I do like to do the visually evoked potential just to say that, okay, you know, from the front of the eye to the occipital cortex is normal. You know, the patient's doing the test right, because this is what you'd expect. You wouldn't expect to see any significant changes in the VEP, visually evoked potential. And likewise, the pattern electroretinogram looks pretty good. There's fairly good signal here. Magnitudes are good. Magnitude D is good. So this patient is normal by pattern electroretinogram. And this gives me a sense of comfort that although there's these suggestive changes in the retinal nerve fiber layer, we know the OCT is also not a perfect test. The field is useless. PERG, VEP is normal. That this patient's stable, we can follow them. We might even be able to reduce their medications. Patients on COSAP twice a day, so you know, it's, you know, whether her peak pressures were 40 or they were 26, 27 or whatever, we might be able to reduce their medicines. So that's just one case. This is another great case, I think, which is very helpful for us, because we get referred a lot of these patients who are high myopes. And this is a big problem because we see a lot of them. High myope, -12, -1150, visual acuity 20/20, pressures 18 in each eye, Pascal pressures 21, 22.8, almost 23 millimeters of mercury. You know, we don't like those kind of pressures, at least as a glaucoma specialist, in the myopes, in the high myopes. Tilted discs, do we, you know, okay, they sent it to me, what do we do? Here's their fundus. This is not this is not a disc that you're going to even be able to evaluate by looking at the patient. So, and this is the field. Also probably not the greatest field taker, with even given her myopia. So now we're sort of striking out at all levels here. And here's her OCT. So her OCT is negative. So now she's got abnormal OCT, questionable visual field, and sort of borderline pressures, and a disc you can't evaluate. So, you know, we're looking at all these things that are tilted. So, of course, I think this is a great role for a pattern electroretinogram and VEP. We did the VEP, basically normal. There was slight difference in the low contrast, but really not that significant. And I think most importantly, here's the pattern electroretinogram. It's completely normal. The signal's strength is good. She's got actually very good magnitudes, 1.8, 1.6. We'd like to see really about 1.2 microvolts or greater as being normal, so she's totally normal. So in this case, I think this really helps us a great deal in helping decide the treatment for this patient. So abnormal thinning, retinal nerve fiber layer thinning, disc hard to follow, PERG normal. We would just follow this patient at this point. So at least we can be comfortable in this. And what we would be doing is repeating this PERG on a yearly basis. So we repeat the PERG once a year in this patient. Another case, MS, visual acuity 20/30, no meds, glaucoma suspect. Does the patient need treatment? 18 and 20 millimeters of mercury. This, you know, we get a lot of these patients and I think you see a lot of these patients in the office. This is some historical data that we got from the patient. So the field looked pretty good. It was pretty stable over time, at least. Again, OCT looks good. We did the OCT. Here's the discs. I didn't have a disc photo. Maybe some suggestion of a little infratemporal thinning over here on the left eye, although the OCT is again normal. Would you recommend treatment? Well, you know, looking at this data, the answer is probably no. I wouldn't recommend treatment. But what we did in this case is I did the Pascal pressures. The Pascal pressures are actually, I'm showing you this because I want to make a point. They're 28 and 30. They're like 10 points higher than her applanation pressures. So we did a study looking at Pascal pressures in glaucoma patients and normal tension glaucoma patients. We found that in open-angle glaucoma patients, the Pascal pressures were 85% of those patients had a pressure difference of greater than 3 millimeters. And in low-tension glaucoma, it was 95%. had pressures greater than 3 millimeters. In other words, greater than what you would expect to find in normal patients, suggesting that these patients are probably running at much higher pressures than we actually think we are measuring, even with thin corneas and taking all the central corneal thickness into account. So we did the VEP, PERG. VEP was normal, which hopefully we would expect. But the pattern electroretinogram does indicate that there are borderline changes. There's some degradation. Their magnitude is actually 0.8, magnitude D 0.73. So there is some reduction in the magnitude and magnitude D in this patient, especially in the left eye, which showed some sort of subtle changes when you looked at actually the optic disc as well. And with those pressures, basically now, this suggests that these pressures are impairing the retinal ganglion cell function. These patients are having, this patient is undergoing stress. Those cells are in a stress situation. So, you know, I recommended that we do get the pressures down. Really looking at not only the applanation pressures, but the Pascal pressures. So we actually are looking at both of this, looking at these Pascal pressures and measuring them. And, you know, I think in this case, one can consider, of course, medications, but we would consider SLT as a therapy for this patient. And you know, just going to SLT, how many people use SLT as primary therapy? Okay, good. So we actually use SLT as primary therapy for just about everybody that comes in who we think needs treatment. And I basically presented to the patients that we have your option of having laser or medications. If you have the medications, you take them every day. If you have laser, there's about a 90% success rate as primary therapy of reducing your pressure to a level that is adequate for the nerve. And it can be repeated in the future. It may not last forever. Many of the patients say, we'll do really 90% of my patients say we'll do laser as primary therapy. So anyway, with that one we would consider doing at least starting therapy. Another patient, I don't know if this was my patient, night vision problems, asthma, visual acuity is 20/25 in each eye corrected, pressures of 22 and 23 millimeters of mercury, good discs 0.4, 0.5, but there is a suggestion of changes on the FDT shown here, may be real, may not be real. There's also some suggestion of thinning of the retinal nerve fiber layer. This was HRT that was done in this case. The reason we're showing this is that they did a pattern electroretinogram, and the PERG did show that the right eye was basically normal, but there was a reduction in the magnitude and magnitude D in the left eye. As you can see, the waveform is sort of decomposing here. And the question was, treat or follow this patient. What they did was they performed SLT on both eyes. I probably would have just done the left eye, but they did both eyes. And they actually showed an improvement in the PERG following SLT. And I think we're beginning to consider, we're using the PERG again to look at the efficacy of our treatments to see if they are showing improvement following laser trabeculoplasty, and as that other study showed, dropping the patient's pressure by 30% is likely to at least show improvement in their pattern electroretinogram. Another patient, male, blurry vision, 20/20, 20/30, 20/25, pressures 21/22. This patient had a splinter hemorrhage on the optic disc, question of a glaucoma suspect. Visual fields, you know, some scattered changes here. It says it's within normal limits. OCT was completely normal in this case. But again, borderline changes in the pattern electroretinogram with a splinter hemorrhage. Borderline changes, so it confirms that potentially these patients are under stress. Those retinal ganglion cells are under stress. Again, this may be related, and you know, there's a good, there's a lot of discussion about the vascular importance of vascular effects on glaucoma, especially low tension glaucoma. You know, how much of this is a vascular disease. So consider treatment in this patient, SLT versus medications. Again, given his pressures, I'd like to see a slightly lower pressure in this patient, so I would recommend treatment and then again follow the pattern electroretinogram. This is another patient we had. I just want to show you this one briefly, but Pascal pressures were, applanation pressures 19 and 25. I actually measured them at 4 p.m., 22, 26, just to look at some diurnal variability in the pressures at different times. Optic disc shown here, not too bad. But she does have a significant visual field defect here. You can't really see much change here though. And the right eye is normal. And actually this confirms that the OCT confirms that there is significant thinning of the retinal nerve fiber layer, although it's not really evident from the disc photo. And we did the VEP, basically normal, a slight difference in high contrast latency. But basically, again, the PERG has some asymmetry here, normal in the right eye, some slight reduction in the left eye. Well, actually, what we did was we looked at this back in 2014. I did another one in 2016, looking at the two to compare them to see how we are and whether we should enhance treatment or maintain the current treatment. And basically, the two, if you look at the numbers, this at the time we didn't have the color coding, but basically if we look at the high contrast magnitude and magnitude D, they're very similar, almost virtually identical, suggesting that the patient is stable. So basically this patient, just wanted to show with those pressures, reproducible PERG over several years, that we would continue her on her current medical therapy. So I don't think she needs any additional treatment. Finally, this is a patient, this is, I think is a retina patient. This isn't my patient, but a patient with left eye who had an ischemic event. So we only have the right eye, and the patient comes in with a blurred central vision, which is in his better seeing eye. He's currently also on timolol and latanoprost and dry AMD as well. Visual acuity was 20/40 or so in the right eye, 2100 in the left eye. Some drusen, some intraretinal hemorrhages, dilated venous tree, and they made a diagnosis of central retinal vein occlusion, mild central retinal vein occlusion. Here's the fundus photograph showing it. So you see the hemorrhages, diffuse hemorrhages throughout. This is the wide field angiography, or early stage and late. So some disc swelling, changes in the retinal periphery as well, some edematous changes, some leakage in the retinal periphery in this patient, some changes of RPE changes in the central macula. So this is these are the retina people. So they did actually a flicker ERG, a high intensity pulsed ERG, using the stimulated mini Gansfeld, which they can talk to you about here. Again, the signal is recorded in the lower lid, similar to what we're doing with PERG. Again, it's a more high intensity stimulus. And what they found was with the, this is the OCT, which actually doesn't show any significant edema, but you're not looking at the edema in the periphery. You're only looking at the back, basically the central macula. But they did the flicker ERG, and it showed this to be actually abnormal. You would expect this phase plot, here it is here. Here's the left eye, which is basically flat, to be more on this infratemporal quadrant here. So it's shifted, and it's given a number 253, which is a borderline phase. They decided, based on this abnormal flicker ERG, to actually inject. So they injected the patient, bezivimab, and then followed this patient and found that there was an improvement in the flicker ERG from 256 to 297. So they decided again, being somewhat the eye, feeling that the eye was ischemic and could go on to develop more permanent changes in edema. The re-inject, so they did a second injection, 279, and then did a third injection. You can see now it's 301, so there's continued improvement in the flicker ERG. So as long as they were seeing improvement, they were basically injecting this patient. And then they did they retested again and found no more improvement in the pattern electroretinogram and basically stopped the treatment. So this is just another use. And one more use for the system, I think, and also this I think is kind of very helpful for our patients. You know, many of our patients like the multifocal IOLs, and a lot of these patients, you know, wonder, well, will this patient do well with a multifocal IOL? This was a patient reduced vision with cataract. She had diabetes, 2 to 3 plus nuclear cataracts, some mild pigmentary changes by AMD. Diabetes wasn't that bad, a single hemorrhage in the right eye. This is the view with the, you know, through the fundus photo, so you can see that it's fairly, you know, moderately dense cataract. Again, we did the pattern electroretinogram. It was actually significantly reduced in both eyes, probably just due to the cataract alone. But we did a multi-luminance flicker and a fixed luminance flicker, which are two other, which are the tests available using the mini Gansfeld. And basically, while the tests are normal by this, there is an asymmetry between the right eye and the left eye. So the left eye is definitely sort of quote unquote more normal than the right eye, suggesting that there are some early changes in the flicker ERG. And likewise, there's a difference in the multi-luminance flicker as well, with some reduction in the overall amplitude, magnitude, and phase of that. Again, confirming that the two eyes are asymmetric. In other words, they're not abnormal, but they're asymmetric. And so given the diabetes, mild AMD, and this abnormal flicker test, I did not recommend that she go with a multifocal IOL. So in that case, we decided not to do it. So I think, you know, overall, its usefulness in clinical management is that really it's an ancillary test. It's a complementary test to all our existing technology. When this is abnormal in the presence of normal and standard automated perimetry or OCT, I think, again, it raises further suspicion on how we should be treating these patients. Again, we're using it to evaluate glaucoma suspects, low tension glaucoma patients as well. Anybody that we basically, you know, things don't make sense. In other words, the disc doesn't make sense, the field doesn't make sense, the OCT doesn't make sense. We're using this to sort of help guide our management. Again, do the changes correlate with glaucomatous damage? Do our tests make sense? Again, using it to evaluate unexplained field losses. We can use it to differentiate other diseases in glaucoma. And then looking at maculopathies, AMD, and even for cataract evaluations using the flicker ERG. So in summary, it's accepted as an additional test when standard test and patient limitations and the subclinical disease processes require objective functional data to aid the diagnosis, disease differentiation, and patient management of diseases that cause vision loss. Thank you very much.